My name is KateJordan. I'm the originator of the Bodywork for the Childbearing Year Advanced Certification Training in massage for pregnancy, labor support, and postpartum massage. What I'm going to be demonstrating today are some techniques that are useful to enable women to recover from pregnancy. When we talk about the postpartum period, we're not talking about just the period immediately after a baby is born, even 2 to 3 months afterwards, but sometimes for 10 to 20 years afterwards. In the United States, very few women get any kind of postpartum follow-up for the changes that occur in their bodies as a result of being pregnant. If you are a massage therapist and you have the opportunity to work with women immediately after their babies are born, there are very few contraindications for body work in that immediate postpartum period. You can massage a postpartum woman within 24 hours of her baby's birth. Observing precautions for any woman who's had a complication in her birth. For example, if she's had postpartum hemorrhaging, you wouldn't do any body work with her until after she's had physician's release. For all of your postpartum clients, it's important to avoid any kind of deep work on the legs for the first 6 to 8 weeks postpartum because of the changes in venous tone and the thickness of the blood or fibrolytic factors that change in the blood as a result of pregnancy. If your client has had a cesarean birth, it's also not appropriate to do any kind of work on the abdomen until after she's been released by her physician. Today we're going to look at 2 particular techniques that address 2 specific kinds of dysfunctions that occur after pregnancy. One is a result of the enormous stress that is applied to the organs of the pelvis as a result of the enlargement of the uterus. In pregnancy, the uterus grows from a shape about the size of a plum to a shape about the size of a large watermelon. And when that happens, the organs of the pelvis and the connective tissue that among which those organs are organized is significantly distorted. I'm going to be showing you now a graphic of the anatomy of the organs of the pelvis before pregnancy. And as you can see, what this graphic shows, starting at the bottom, is first the bladder, above it the uterus, and above it the rectum. And those 3 organs do not exist discretely in the abdomen. Instead, they are enmeshed in a matrix of connective tissue. And among that connective tissue are the broad and the round ligaments. The broad ligament actually has the fallopian tubes and the ovaries embedded in it. As the uterus grows in size, from the size of a pear to the size of a watermelon, all of that connective tissue, the ligaments, fascia, suspensory ligaments, all of those structures become disorganized, stretched, and strained. What we're going to be doing now is a technique to help to reorganize that tissue. And this is called the uterus bladder lift. This is a visceral technique. I'm going to be demonstrating it on my model, Dana, who is very recently postpartum. So this is Dana, and Dana is recently postpartum. We know that all of the tissue in her pelvis has been disorganized as a result of her pregnancy. This can have a significant effect on the function of her bladder. She can become incontinent. She can have issues with prolapse of the bladder, prolapse of the uterus, prolapse of the rectum. It can also cause vague pelvic pain as well as back pain in the postpartum years, and these postpartum years can last for 10, 20, 30 years postpartum. I'm going to do a form of myofascial release, but it's going to be visceral release. I'm going to be moving very, very slowly down through the tissues of Dana's pelvis, starting at the skin, moving through superficial fascia, fat, down to the bladder, potentially down to the uterus, potentially down to the rectum, depending on whether or not her tissue is restricted. I'm going to place the pads of the first 3 fingers of both hands just superior to the pubic bone. And I'm going to slowly let those pads sink down. And as I sink down, I'm aware of how Dana's tissue is responding to my hands. Every time she takes a breath out, I'm going to let my hand sink just a little bit deeper into her pelvic cavity. And when I've reached the point of restriction, where the tissue begins to talk back to me, this is the furthest that I can go in her tissue. And right now, on Dana's abdomen, I've sunk through the bladder, and I'm down at the level of the uterus. Dana, what I'm going to ask you to do is take a breath in and take a breath out. And on your next breath out, what I'd like you to do is breathe out through your mouth, and that'll be on your next breath. And then after you've taken that breath out, hold your breath and suck your abdomen up towards your chest. And as she does that, I'm going to create a tensile stretch at the level of the bladder deep in her pelvis. I'm going to hold this for 5 seconds and ask her to release. I'm going to repeat this one more time, Dana. And now, Dana, you can relax a little bit more because you know what I'm going to be doing next. And every time Dana takes a breath out, I let my body weight sink into the pads of my fingers. And on this second repetition, I'll be a little bit deeper. And now, Dana, on your next breath out, I'm going to ask you to breathe out through your mouth. And then pull everything up. That's perfect, perfect. I'm going to create that tensile stretch of the tissue. This actually reorganizes the bladder, the uterus, potentially the rectum. I'm going to hold that for a minimum of 5 seconds and let it release. In a typical session, I'll repeat this 3 times. A number of strategies that are inappropriate to use with the uterus bladder lift include sinking down as far as you possibly can, and then as you pull up, scooping and sinking even deeper. I'm not even going to demonstrate that on you, Dana. That hurts. Also, one does not want to sink down and then drag and pull across the skin. So the position that the hands, their interaction with the skin at the initiation of this technique is where those fingertips should be at the end. So the fingertips are super glued to the skin. So it's the skin and the superficial fascia that are moving with the fingers at the level of the deep viscera. In this particular technique, I would repeat in 2 to 3 sessions, as well as 2 to 3 times in each session. This technique is also useful for individuals that are suffering from menstrual cramps. We're going to look at another area where women have significant dysfunction in the postpartum period, and that's in the area of the structural organization of the pelvis in relationship to the lower back. As pregnancy progresses, as that uterus grows from the pear shape to the large watermelon shape, the entire body changes, not only in its structural organization, but in the proprioception, in the template that the cerebellum has of where the body is in space, and all the proprioceptors and ligaments, tendons, joints. Many of us have seen women postpartum who look as if they're still pregnant, that look as if they're still 5 or 6 months pregnant. Their bodies have not readjusted to their pre-pregnancy state. And oftentimes this is a result of a shortening or strain in the psoas muscle. The psoas muscle is the primary postural muscle of the lumbar spine and pelvis. We are going to work with the psoas muscle directly using a technique called strain and counterstrain. Strain counterstrain is an osteopathic technique that was developed by Dr. Lawrence Jones in the 1950s. And strain counterstrain relies on the inhibition of aberrant impulses from specialized nerve cells called spindle cells that wrap around individual muscle fibers and report back to the spinal cord and the brain on how much a muscle has stretched in motion and how quickly it's stretched. We can address the psoas muscle in an extremely effective, non-painful way using strain and counterstrain. I'm going to show a graphic now of the particular points that we'll be addressing in the psoas muscle. And there are 5 points that will be touched in the psoas muscle to look for the most tender point to be extinguished if there's dysfunction in this muscle postpartum. And as you can see on the graphic, the first of these points is superior to the crest of the ilium. The second point is at the level of the ASIS. The third at the level of the ISIS. The fourth at the level of the inguinal ligament. And the fifth at the insertion of the soas on the femur. I'm going to use a deep fingertip pressure to address all of these points. So to look for tender points in the psoas muscle, I'm going to palpate midline at the crest of the ilium, laterally, just medial to the anterior superior iliac spine, just medial to the anterior inferior iliac spine, over the inguinal ligament, and then on the attachment of the psoas muscle on the femur. And I'm going to use enough pressure that my client can feel the touch, but not so much pressure that it's excruciating. So I'm going to palpate these 5 points on Dana, and I'd like you to tell me, Dana, which one of these hurts the most. Got point number 1 above the crest of the ilium, point number 2, ASIS, point number 3, ISIS, point number 4, inguinal, point number 5 on the femur. Which one of those hurt the most? Point number 2. So this is the most painful place, and I'm looking for a level of pain that's significant. So using a pleasure pain scale from 0 to 10, I'm looking for an amount of pain, Dana, that felt like a 5, something that was a little bit more than comfortable.
Yes.
What I'm going to do now is manipulate Dana's leg in a way that will shut off the aberrant impulses from the spindle cells in the psoas muscle. And I'm going to do that by bringing her leg first into flexion and then either into lateral rotation or medial rotation. So I'm first bringing her leg into flexion, and then I'm going to bring her into lateral rotation and see what a difference that makes in her pain perception. And while I have been moving her leg into this position, I have no longer been pressing this point. I'm going to press the point again and get feedback from you, Dana. Does that feel better, worse, or the same?
Better.
On that scale of 0 to 10 that we're using, what does this feel like?
2.
Okay, I'm going to move you just a little bit more, and the hard part is for you not to help me.
Okay.
How's that now?
0.
Good. So I'm going to ask you to imagine now that you're a Thanksgiving turkey, and you're completely cooked. And somebody's coming in to check your leg to see if you're completely cooked.
Okay.
And that means this is going to be a very wobbly leg.
Okay.
And I totally have your leg here. Now, the way that strain counterstrain works is by repositioning a joint or a muscular structure into the position of original strain. I need to hold Dana in this position for 90 seconds. Not 30 seconds, not 60 seconds, but 90 seconds. And while I'm holding her in this position, very, very slowly, there will be an extinguishing of the aberrant impulses from the psoas muscle and also from spindle cells that are related to the joints of the lumbar spine on which the psoas muscle originates. And so as I hold Dana in this position for the requisite 90 seconds, I'm going to ask her with every breath that she takes out to continue to allow her body to relax just a little bit more. And you really are doing that. And as the muscle begins to unwind, the vascular flow around the muscle increases, and that's what you as a therapist would be perceiving under your fingertips. For the entire length of time, for the 90 seconds that I'm holding her leg in this position, there's no pressure from my fingertips on the point, the tender point that I palpated. So I have my fingertips on that point, but I'm no longer palpating deeply. I'm only monitoring that position. After those 90 seconds, I'm going to bring Dana slowly back to her original neutral position. I'm going to recheck the point. And what does that feel like, Dana?
0.
So it doesn't hurt any longer. So this is a very simple, elegant, pain-free way to extinguish tender points in the psoas muscle. What might Dana have been experiencing if she did have this dysfunction postpartum in her psoas muscle. She might have what she experienced as severe hip pain. She might have difficulty riding a bicycle for a long time, walking, getting up and down stairs. She might have lower back pain. She might also have vague, undefined complaints in her lower abdominal area, all coming from the psoas muscle. You saw on the graphic that there were 5 tender points that one palpates for the psoas. The first of those 5 points, the point that is just superior to the crest of the ilium, is extinguished in a different way than points 2 through 5. The first point is extinguished by changing the order of the 2 motions that are done to extinguish. And in order to extinguish that point, that high point, before I flex, I'm going to laterally rotate. So I'm going to laterally rotate Dana's leg and then flex it. And because I have a bolster here, I have the half moon bolster, because her leg is resting on that bolster, I no longer need to hold her leg in that position. So this is the way that the first point of those 5 points would be extinguished, and this is always the case. Whenever you see a postpartum woman, you want to check her both for restrictions in the viscera, in the connective tissue around the uterus and bladder, and also for significant dysfunction in the psoas muscle. I want to thank Oakworks for providing me the opportunity to share this information with you. Thanks.